네, 시청자 여러분 안녕하십니까?
Hello viewers, this is case discussion to share clinical problems with us. Today, I'm looking forward to the solutions to the clinical problems. We have invited 3 guests. Hello. In order to address problems, our viewers are waiting for our guest discussion. Today, we are going to talk about complex cases. Patient is 45-year-old male, no specific disease, but he has a strong bite force. 1 year has passed since the extraction in the upper right posterior region due to the patient's indecisiveness. On the right, without vertical bone augmentation, sinus graft, and at the same time implants were placed. For the upper left posterior number 26 missing area, do I need to do vertical ridge augmentation or just sinus bone grafting like the right side? This is the initial visit panorama. Number 16, hopeless tooth is observed. Here, the right posterior teeth are extracted. However, number 26, the bone resorption is quite serious. If you look at here, 1 year has passed since the extraction. On the right, the bone is resorbed up to the basal bone. Next, sinus elevation is done and 2 implants are placed, and number 26 is extracted. The questioner is worried about number 26, and after that, CT was sent in to us. The residual bone of number 26 is just 1 or 2 millimeters. The next CT shows the overall situation. Number 26, the residual bone is almost non-existent. In this case, it's a very difficult case. What do you think about this? After extraction of number 26, if you look at number 25 and 27, there's a bone near the teeth, but in the CT, buccal and the palatal bone all disappeared. In this case, before extraction, socket preservation should have been considered. Right now, extraction is already done, so the questioner is worried about the vertical bone augmentation, whether it should be done. If you do sinus graft only, the crest part of the implant will be near the root of adjacent tooth. So it will interfere with the cleansing. I'm at a university, so I don't do a lot of socket preservation. Dr. Sun, what do you think? It's a very unfortunate case, and it could have been avoided. However, the time has passed, creating the problem. In quadrant 2, teeth are extracted. When you extract teeth, socket preservation could have been done together. Then the treatment could have been easier, or the difficulty of treatment must have been reduced. When bone loss is serious, during healing, hard tissue would disappear and the shape of the architecture of soft tissue would collapse. That would be more difficult than forming bone. With extraction, socket preservation or other approach should have been considered. I agree. Before something happens, we need to think what will happen in the future. That means treatment should be planned, whether we'll do socket preservation with extraction or GBR after extraction. That should be thought beforehand. And we need to think about the prognosis of adjacent teeth to determine whether will extract just one tooth or more. In order to cover the mistake, unreasonable attempts can be made, aggravating the relation with the patient. So it is really unfortunate. Treatment plan was not established before extraction. It is very difficult to go back to the planning stage. This has hit a snag. Vertical augmentation can be done, but soft tissue augmentation is to be done first. Very, very bad situation. So it was a simple problem, but it has gotten out of control. Very challenging case, so I wonder what treatment can be done by our experts. Dr. Son, would you explain what you have prepared? I brought a case. Most basically, when heart tissue is lost quite seriously, when implants cannot be placed, the loss of heart tissue and preservation of soft tissue can be preserved using socket preservation. In this case, in quadrant 1 bridge, the bone is lost severely at the mesial side of the posterior abutment of the bridge. So extraction was the only option. As you can see, basal bone is almost non-existent, and the sinus can be damaged. Therefore, extraction together with implant placement can be risky. On the CT, over the root, of course, we can place implants if we are determined to do so. However, the patient agreed to socket preservation and the delayed implant placement was planned. The bridge is cut and it is extracted. On the mesial side, a lot of calculus is observed. For socket preservation, we get question a lot. Do we need to remove the granulation tissue there? How can we cleanly get rid of them before using curettage? On the crystal level, granulation tissue should be incised in a circular form, so it is in one lump sum, and that can be taken out. After the incision, the granulation tissue can be taken out in one piece. That is the cleanest way. And the graft material is important. FDBA cortical chips are used. There's no wall, so I classify the case with walls and no walls. When there's a wall, I use only autogenous bone. If there's no wall, I mix xenogenic bone in 1:1 ratio. In terms of the membrane, PTFE, which is controversial, is used. Some people like it. Dr. Kim doesn't like it. I currently use collagen membrane for socket preservation unless the defect is big. PTFE membrane is used for the socket preservation. We need to be careful in suturing. Here in this picture, it is quite tense. You need to have it more tension-free to get better outcome. In other words, in order to make small opening, you shouldn't pull the suture. The tension on suture would generate poor outcome. On the CT, we can see the grafting. After 4 weeks, PTFE membrane, the outer surface is contaminated, so it is removed with a pincet. Granulation tissue is below. This is called the pseudoperiosteum. After 4 months, bone is well formed. As you can see, there was no buccal bone, and no soft tissue collapse happened, and bone is regenerated. Using a casket, implants are placed, and completed. On CT number 6 and 7, sinus is a little bit raised to place the implants. No grafting. After 9 months, we waited a long time, sufficient time, and prostheses were delivered before completion. On the panorama X-ray, I want to show you, this is a magnified picture. As you can see, the trabecular pattern in the grafted bone is different. So that is inevitable when we use a xenogenic bone. The graft bone particles remain. If you don't like it, autogenous bone only can be used. But when there is a defect, there's a lot of remodeling amount. So autogenous bone only cannot make a bone like this well. If there is a defect, slowly resorbing material should be used. If the wall is sound, the fast resorbing and the regenerative autogenous bone can be used. So socket preservation can be done like this to preserve hard tissue and soft tissue to place an implant. This protocol can be applied to where the defect exists or not. Dr. Son said, I don't like a dense PTFE membrane. Actually, at one time, the Gore-Tex-like expanded PTFE was used. When infection occurs, it was a serious problem to remove it. So dense PTFE membrane was quite popular at one time. Personally, I don't like it. As Dr. Son said, PTFE membrane can be exposed. So over time, 4 to 6 weeks after, the outside surrounding gingiva looks pretty bad. I don't like that. So that's why I do not like it. As Dr. Son said, after bone grafting is done, even collagen membrane is exposed. You just leave it like it. Of course, a minimal suturing should be done. Not very tense suturing you saw before. In my case, the amount of preservation bone graft can be reduced, but it's cleaner. So recently, I used 2 layers of collagen membrane, or as other European gurus said, connective tissue graft can be done, but as I briefly mentioned last time, Korean patients do not like pains, so palatal bone harvest would create a lot of complaints, so I tend to use collagen membrane. So Dr. Yang has prepared a case. As Dr. Kim said, everything what he said is contained here, and it contains my success and the failure cases. In 2003, the patient came to us. Serious periodontal disease is observed. It's not indicated here, but he's a heavy smoker, 2 packs a day. Very stylish patient, gold chains all over the body, and very nice watch. But intraoral situation is very poor, and oral hygiene is very bad. And he's very busy, doing business, always busy. So he wants everything done quickly, but it's not easy for us. So posterior region, quadrant 1, I was thinking about what needs to be done, and number 37 and anterior region. So our hospital tried to accommodate his wish, even though it's difficult. Serious periodontitis and heavy smoker, very challenging case. This is old pictures turning into slides. The picture quality is very poor. In 2003, the patient came to us and extraction was done. The PTF membrane we had was used for socket preservation. The buccal bone is abundant here. If it were today, we would have used a different approach, but at that time, we work like that. As you said before, I try to cover that with CT. However, mesial side of 17 is a little bit exposed. And after 3 weeks, as you can see, and as you said, this is the typical symptom of DPTFE. The unexposed part is healing very well, but the exposed portion, the problem is getting aggravated. So in this patient, it is not included in the picture, but the problem has gotten large. The membrane should be covering the site for at least 6 weeks, and the problem is getting larger during that period of time. At that time, I tried to maintain the membrane for 8 weeks, but I had to remove it because the problem had gotten worse, and the soft tissue surrounding that area would become very poor. So rather than the DPTFE membrane, I prefer to use a resorbable collagen membrane. Like Dr. Kim, I do the same. Now, horizontal and vertical status is maintained, and sequentially, if you look at here, the socket preservation is used and the GBR is done. Implants were placed after 6 months, and secondary surgery was performed, and prosthesis was completed. If you look at this round circle in red, number 37, I was wondering, if I do not do socket preservation, what will happen? So, if you look at here, 2003 September, before that, tooth was extracted. Due to pair reasons, I believe the tooth was extracted. I was paying attention to the posterior of maxilla, and the body spontaneously heals the site. Something is changing, and after 6 months, if you look at number 37, you can see it is being healed, and after a year, so in October 2004, the site is almost healed spontaneously. What I felt at that time was, is it good to intentionally make bone or wait until the body makes the bone? If we can afford to wait, the latter would be better, but waiting is difficult. 1 year of waiting is difficult for us as well as the patients. Erratic wound healing is also described in paper. That means the bone cannot be made after a year. That means a year of time can be wasted. It's not reasonable. So the socket preservation or socket augmentation procedure is not necessarily to be avoided. So if you look at the case sent by a viewer, various problems occurred because the treatment plan was not properly established. Here, we just delayed the treatment planning, and I learned a lot from this case. In establishing treatment plan, it would be nice to discuss this possibility with the patient as well. Thank you. I have a question. When you have a periodontitis, it can migrate to adjacent teeth. So the adjacent teeth can become mobile. How do you determine to save or remove the tooth? I think it was last month. About 2 months ago, we talked a similar topic. Furcation involved the tooth. I tend to save it, but others prefer to extract it. The mobility will be decreased after treatment, so I don't determine the prognosis based on mobility. Mobility is important too, but overall it is not the very important thing to consider. it should be re-evaluated after treatment. And if mobility still persists, you need to re-evaluate the site again to determine the prognosis. So, height of the ridge, probing depth, mobility, and compliance of patient should be considered overall to determine prognosis. If the prognosis is questionable, initial treatment should be provided and re-evaluation should be done to decide on the prognosis. Thank you very much. Dr. Kim has prepared a case. As Dr. Yang talked about socket preservation, the opposite side healed quite spontaneously. Talked about immediate placement maybe last month. Our dentists actually want fast treatment just like our patients. So natural healing, spontaneous healing capacity of our body can be seen in this case. The patient has a periapical cyst at number 15, which is entering into the sinus cavity just a little bit. And the patient was referred to me because of the possible oral fistula opening after extraction. If you look at here, on the panorama, it is not clearly visible. I didn't have a cone beam CT at the time. At number 15, apical lesion is growing into the sinus. So when I removed it, I removed all the way up to the periapical cyst as well. I didn't do any treatment there at that time. During healing, the patient didn't come back. So 11 months passed, and almost 1 year after implants were placed. So it looks like as if a bone graft is done using a crystal approach, bone is growing into the sinus. We do a lot of immediate placement in the upper anterior for aesthetic reasons and to prevent the labial bone resorption. However, sometimes we can wait for the healing of extraction socket and we can do socket preservation. This is not directly related to implant, but if you look at here, 45-year-old female patient, left ramus, number 8 is pushed toward the root of number 7. So dentigerous cyst involves a whole ramus. Number 7 could not be saved, so they're all extracted and the cyst was scraped out. We didn't have a residence, so I didn't do bone graft. I just did the primary closure. So after 3 months, spontaneous healing. After 6 months, when the patient came back, I said, we can place an implant, or if the bone, as it was a cyst, if the bone quality is not good, bone grafting can be done. And the patient, due to economic reasons, delayed the procedure. So after 1 year, 2 years, and after 3 years, the patient came back and the patient wanted an implant, and I took panorama picture. The bone looks very good. No bone graft is required. After 3 years, without any bone graft, the routine implant placement resulted in like this. The cyst, which involved the whole ramus, spontaneously healed without any treatment. A little bit of vertical bone loss is made, but you can see the spontaneous healing capacity. As Dr. Son said at the beginning, the case sent to us by one of the audience, and as Dr. Yang said, if we properly establish plan, what happens to the adjacent teeth if bone is available at number 5 and 7, socket preservation can be done to get better outcome. And one more thing, I have prepared the case sent to us by one of our audience. I have a similar case of mine. I would like to show you. In this case, In 2008, the patient came to me. Number 16 is extracted. And number 15 and 17, a bridge is delivered and alveolar went down. So food impaction caused the discomfort. And the number 26 is extracted. And the patient feels very discomfort on the opposite side, and the patient wanted an implant for number 26, so the patient was sent to me. This is similar to the previous case. Bone loss is occurring at number 26, and there are some bone for number 5 and 7. If you do sinus graft, implant should go very deep, so the implant will not have good relation with adjacent teeth. So I suggested vertical ridge augmentation needs to be done with autogenous bone, and the patient is in the 60s, but the patient has strong chewing force. On the CT, if we have a buccal and palatal bone, it's easier, but the bone is all gone, almost gone, so I considered a block bone graft. Here, vestibular incision is made. The third picture at the top on the right, this is old picture, so it's not very good. Below the sinus floor, dissection is made and it is exposed. A window is created with a lateral approach, and a block bone is harvested from ramus. That's the donor site. Block bone is trimmed. I believe it was 2008. We had a big issue of mad cow disease, so I used bovine bone with autogenous bone, but at that time people did not like bovine bone, so Cerasorb was used, beta TCP. Not very good. Below the sinus, block bone is entered and bone graft is done in the sinus. So if you look at here, immediate post-op, below the sinus floor, you can see the block bone and sinus graft is done. Sinus graft and residual bone crest received autogenous bone graft. After about 5 months, SS implant was placed and temporary was delivered. 3 years. After about 6 years, it looked like this. The patient is very satisfied because the food packing and the discomfort experienced on the opposite side with the bridge, the patient is very satisfied with this option treatment. As I said before, if the condition was very well preserved, it would be very good. But when a disaster like this happens, autogenous bone block graft was used. I cannot explain further, but I have many similar cases using autogenous bone, and the people suffer pain when we harvest block bone from ramus. Allogenic case is also available, but it doesn't have as good outcome as this. But autogenous block bone needs to be used in this case. However, we need to prevent this situation develop. I thought about this case when I heard of the case sent by one of the audience. So, as was discussed before, we need to establish overall treatment plan properly to prevent a small problem to grow into a big one. Regarding the case under discussion, do you have anything else to add? Looking at the case, I felt there are many similar cases for solution. We talked about GBR cases at the first or second discussions, resorbable or non-resorbable membrane or os builder. I believe this is a good candidate for os builder. In this case, the most important thing is the bone level in the adjacent teeth, mesial and distal bone level of number 5 and 7. So if you cannot treat that portion, then we may have to extract the tooth most unwillingly with tearful eyes. As I said in the beginning, we need to establish proper treatment plan. You asked about the adjacent teeth. We need to look at the adjacent teeth to decide on the prognosis. You need to consider whether you are skilled in block bone graft, socket preservation, and others. Therefore, you need to consider various things overall. So this is a very complex case. Dr. Song? I agree with Dr. Yang and Dr. Kim. Various things need to be considered. In a case like this, establishing a treatment plan is the most important thing. Regarding this case, just like Dr. Yang, I am most troubled by number 5 and number 7. While looking at this, I want to do the bone augmentation, but when we open and bone is up there, we can't really do. So maybe I kept thinking I have to extract number 5. The questioner dentist must have discussed with the patient the possibility of extracting number 5. Thank you very much. We need to adhere to the basic principles, especially when we are in trouble. Everybody will face difficulties at one time or another, and when we are in trouble, we need to go back to the basic principles. Once again, I would like to thank the participants, Dr. Yang, Dr. Son, and Dr. Kim for joining us. Thank you very much. I've been Dr. Jung Young-eun. I'll come back next time. Thank you.
수고하셨습니다.
수고하셨습니다.
네, 수고하셨습니다.
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 안녕히 계세요.